Hello, and thank you for taking the time to jump in on this presentation. I'm going to do my very best to keep it pretty brief. I know everyone's busy with a list a mile long of things to complete. My name is Caitlin McGregor. I'm a treating occupational therapist. I serve as a therapy program manager for one of the sites that TMI serves. I am also a licensed nursing home administrator and MRAC CT certified. We're going to spend some time today talking about the discharge function score, which is one of those new measures from CMS, one of those updated measures that's impacting our QMs and our 5-star status. The specific quality measure that we're looking at reads the percent of residents who are at or above an expected ability to care for themselves and move around at discharge, aka the discharge function score. We're going to look at some variables that go into the score, where the data that makes up the score is coming from, and provide some recommendations for your team moving forward. The specific aim of the discharge function score is to provide valuable information about the quality of care received, and then further on to predict success rates with return to community and rehospitalization rates. It is derived from data that we're putting into the MDS on admission and discharge. What we're putting into admission is then deriving what that expected score is, and then they're looking at our discharge MDS to say, did they meet that? Did they meet that expected value? Our goal is to meet or exceed it. CMS has not released what the calculation is, what the formula is to come up with this discharge function score. And as far as we can tell now, they don't have plans to. So to add another layer, our goal is to reach a value that we don't know. Looking specifically at this measure, we're looking at 12 months of data, and we're only using stays that are defined within the metric. So those being complete stays or interrupted stays with that 3-day or less gap in them. Incomplete stays are automatically being excluded. So those that are being discharged to acute care, an unplanned discharge, someone leaving against medical advice, less than a 3-day stay, or a death that occurs in facility. Those are automatically excluded, not being counted towards this measure. To acquire our facility observed percent, we're looking at the number of complete stay cases that met that anticipated discharge function score. The ones where we met the bar, we exceeded the bar, we did what we needed to do in the eyes of the expected discharge function score, divided by the total number of eligible complete stay cases that we had. The discharge function score is noted on the IKEYS report. On this slide, I have a shot from both December and January. We're looking at that 12 months of data here. So in December, we were pulling data from the entirety of 2024. And then as we moved into January, the quarter shifted. We began looking at April 1st, 2024 to March 31st, 2025. With that facility observed percent, one thing to note, a facility with a smaller pool that they're pulling from is going to see greater fluctuations in percentages. One number change in the numerator or denominator can have a greater effect on that facility observed percent. The key item here is that we are above the national average. That's the big goal. As we look at this list, we're identifying 11 clinical categories that make up the covariates or risk adjusters for the discharge function score. We can identify that the information that we're putting in here is either raising or lowering the expected score. Now, some of these are static, like the age category, and others are more dynamic, like the admission function score, where information that we're gathering from our clinical skilled assessment may have an impact on what the score is. The key here is that the more complex a resident is, the lower their expected score is going to be, which is why it's very important that we get a thorough, full assessment. As we look at some of the categories that we can have more of a dynamic impact on, such as the admission function score, we want to identify who should be the key players that are bringing information to MDS, to the IDT, to determine what that usual performance is. We need to be hyper aware of what that look back period is so we can make sure that we're collecting enough data to make an informed decision on what that usual performance is, along with using all of our clinical reasoning skills to really identify who is this patient, how are they performing, and then ultimately, what can we do to drive them to success and drive them to meet that expected discharge score. These are the 10 categories that go into the admission function score. So these items are coded in section GG. They're scored on a 1 to 6 scale, 1 being dependent, 6 being independent. We also have these activity not attempted codes, reading as the resident refused, we didn't attempt it due to environmental limitations or restrictions, it was not applicable, or it was not attempted due to a medical or safety concern. So if we're using an activity not attempted code, CMS is going to do some imputation and use some arbitrary value for the item that was not scored. As we look at section GG, this is really where it's going to be beneficial for your team to identify where is this information coming from. Are we only using it from perhaps the therapy evaluation? Are we only using it from the aide's first 2 days of charting? So this is where we want to look and identify where are we getting our information from? Are we capturing information from that entire available look back period? And how are we defining what usual performance is? TMI has recently taken the initiative to train our therapy program managers, who are then able to provide in-services to their team related to the discharge function score, section GG, and how our therapists can be active members of the IDT. Internally, we have supports available in documentation auditing to provide feedback on the quality of documentation, as well as assistance with program development and clinical support. We are committed to monitoring for developments related to the discharge function score and providing those updates to our teams and customers as they arise. We're going to take some time now and look at what some key considerations are as we look at this metric and how we can best approach it as a team. As we look at the IDT, we first need to identify who's on our team, nursing, therapy, dietary, social work, etc. We need to meet regularly, ideally within that look back period, so we can identify what usual performance is, capture anything that we're missing, and identify what that usual performance is, making sure we all agree on it. And how are we documenting it? Is it in an assessment? Is it on a form? Is it just writing a progress note in the chart to say IDT met this date to determine usual performance? Usual performance is as described, and then spelling it out from there. Now we're going to transition into looking at what are some communication tools that we can potentially use to benefit and lead the conversation for the IDT. The 3 forms that we're going to look at here are not mandatory for your team to use, but they may be beneficial as you look at leading conversation and leading what your IDT needs to look at. So this is an example form of an admission meeting. We look at what their insurance is. We start creating a discharge plan immediately. We're looking at what was in the hospital. Are there swallowing concerns? What was prior level of function? Current level of function? What barriers might we find as we continue through this resident's plan of care? So this is a great way to identify at the beginning, what do we have, what's missing, and where do we need to go? We can then transition to looking at a discharge planning form as we edge closer to discharge. So now we're looking again at what's my discharge date, how am I performing, what is my plan now for discharge, and what do I still need as I approach discharge. This is the MDS data report that therapist or the therapy program manager can run. It will contain information related to number of minutes spent treating, identify the diagnoses that were used, and then the GG performance for both mobility and self-care. So this is a snapshot of part of one of those reports. We can identify the admission performance, the goal that the therapist set, And then once discharge happens, we'll be able to fill in that discharge category. This can be very useful as we look at our admission MDS to identify how were they performing at therapy evaluation. Again, that's not necessarily saying that's the number we need to go with, but it's good information to add in as we look and consider. In the research that we were able to complete, it was identified that the discharge summary is an area that's significantly lacking thorough communication and understanding between all disciplines to identify what that true discharge performance is. Some areas for your team to consider here. Are we having a pre-discharge meeting? We've now identified that the resident is nearing discharge. Are we sitting down and saying, okay, how are they doing with therapy? How are they doing with nursing? Where do we have gaps? How can we bridge that gap to get them to their most independent? What was their prior level of function? Are we reaching it? Are we meeting it? Have we exceeded it? Where are we lacking? I'm identifying what the look back period is for that discharge assessment to make sure we're truly capturing what their performance is. And then again, running that MDS data report once the therapist discharge has been completed to provide that to MDS to have another resource to look at as they're looking at deciding what's being submitted and signed on the MDS. The last piece that I want to mention is that the goals that therapy is setting is not impacting the discharge function score. Therapy can set every goal to be independent, and it's not changing what CMS is putting into their expected discharge score. Circling back to the beginning, this is derived from the MDS and information put into the MDS. So while therapy plays a key role in identifying and progressing patients as they go through their course, the goals that they set are not specifically impacting the score. Thank you for taking the time to listen to this presentation. I am more than willing, as are Kim and Donna, to collaborate with you and your teams regarding how TMI and their therapists can partner with you to champion this new measure and optimize that facility observed percent. Our goal is that all of our facilities are well above the national average and really showcasing all of that wonderful care and that above average care that our patients are receiving. Our emails are listed on the slide here, so don't hesitate to reach out. Again, thank you for your time and have a great rest of your day.